First of all, I'd like to introduce Dr Zaman. He's a respiratory physician and lead for lung cancer at Royal Blackburn Hospital. So Dr Zaman, my first question to you is, what types of patients should a GP have a high index of suspicion for lung cancer?
I think we already know that most of these patients would be either smoker or ex-smoker. So if somebody is, say, above 50 years of age and they are either smoker or ex-smoker and they've got certain symptoms, and in the symptoms we can either use the NICE guidelines which tells us about the symptoms, or primary care cancer risk assessment tool. And most of these symptoms would be like cough, shortness of breath, chest pain, weight loss, loss of appetite, and importantly hemoptysis, either in combination or as a single symptom. So if the patient is having those symptoms, we should have a high index of suspicion. Secondly, we already know that most of these patients also have got a chronic obstructive airway disease. So especially if they have got an abnormal spirometry or if they have got a clinical signs like clubbing. So then these patients should either be sent for an X-ray, or if you are very suspicious of a lung cancer, then they should be directly referred to without waiting for the report of the X-ray, to the lung MDT.
What is the value of a chest X-ray in early detection of lung cancer?
I think there are two issues with chest X-ray. One would be that if you are having all these symptoms which we have described, and if you do an X-ray, you might pick up the cancer, which the diagnosis might be delayed because of the fact that you didn't send them for an X-ray. Now, the second more important question would be that whether doing these X-rays you are detecting early lung cancer, and these patients then can go on and have a curative treatment. I think evidence for that at the moment we haven't got it, and it would be that studies should be done which would look at that if we are picking up the cancer in the early stages and then these patients are going for a curative treatment. But I don't think at this time the evidence is for that. But at least you are making the diagnosis of lung cancer earlier on if you are doing the chest X-ray. Second important factor would be that if the X-ray is normal, that doesn't mean that the patient hasn't got a lung cancer. So if they have got a symptom suggestive of lung cancer, then even with the normal chest X-ray, you should refer the patient to two-week rule clinic. And the lastly would be that there might be the X-ray abnormality which might not get reported as lung cancer, but it might just say that the consolidation which is present is not resolving, or the patient has got a pleural effusion. And again, you should send these patients to the two-week rule clinic if they've got a symptoms of lung cancer.
Please, could you briefly outline what is the management of different types of lung cancer?
I think broadly speaking, there are two groups of lung cancers. One is called small cell lung cancer and one is non-small cell lung cancer. Small cell lung cancer is possibly 10 to 15% of lung cancers are non-small cell lung cancer. And that, apart from very small proportion of those patients who might be fit for surgery, but most of them would be either getting concomitant chemo and radiotherapy or chemotherapy on its own. And after that, if they show a good response, they might go for prophylactic cranial irradiation. So small cell lung cancer, chemosensitive, rapidly aggressive tumor, so the treatment is mainly chemotherapy. Then the main group is non-small cell lung cancer. And again, it would depend on the stage of the non-small cell lung cancer, the comorbidities, like if they've got significant COPD or heart failure, etc. and the patient wishes. But say if it is an early lung cancer and the patient is otherwise fit, the best thing would be that they would go for surgery. If on that group of patient, if the surgery is not possible because of other comorbidities that they can't stand the surgery, then you can consider curative or radical radiotherapy. So that is the treatment for curative intent. Now, some of these patients who are going for radiotherapy, they might not be fit for radical or the conventional radiotherapy, but they might still go for a stereotactic radiotherapy or radiofrequency ablation. So that is again other new things which have developed recently. But otherwise, 2/3 of the patient, as we know, when they present to us, are not for the curative treatment. So that group of patients, if they've got a good performance status and the cancer is advanced, then we would offer them chemotherapy. But if they have got not a good performance status, then they would be going for palliative treatment, which might also include palliative radiotherapy if they've got a bony pains, etc.
And finally, why is the prognosis of lung cancer so poor? And what could be done to improve the survival?
My opinion, there are two main issues which if we can improve, hopefully that would improve the prognosis of the lung cancer. As we have already discussed, that unfortunately 2/3 of the patient at the time of presentation can't have curative treatment. So the main important thing would be that if we can detect the lung cancer earlier on, so we can avoid the late presentation. And that would mean that we are increasing the awareness in the public, that if they know that what are the signs and symptoms of lung cancer, they are going to their general practitioner. General practitioner again are doing an X-ray or referring them quickly to the secondary care. And then secondary care, the systems are there where they can be investigated quickly. So if we can bring this late diagnosis, improve this thing, I think that would be quite helpful. And the second thing, out of all the treatments which we have discussed, the treatment which in fact has got the biggest impact would be the surgery. So again, if the surgical rates can improve, again, hopefully the prognosis would improve. And the surgical rate in this country are perhaps between around 15%, and in other countries it is more than 20%. So again, the surgical rates are less, and that would the things how we can improve that, I think we have to have a very good MDTs where these patients are discussed. If they've got any comorbid conditions, then we try our best to improve that so that they can have a surgery done. Third, if they are borderline cases, then there are things where we can have a second opinion. So if one surgeon turns them down, the other person might be able to do the surgery. And lastly, also that the MDT is proactive, and they are referring the patients to the surgeon. Other problem in this country is that we have got a few thoracic surgeons. So if we have got more thoracic surgeons, then again, I think surgical resection rates would improve.